it's a privilege to introduce our STS president. He's a renowned heart and lung transplant surgeon-in-chief at the Johns Hopkins Hospital, William Stewart Halstead Professor of Surgery, Director of Department of Surgery at the Johns Hopkins University School of Medicine. Please help me welcome Dr. Robert Higgins.
Thank you so much, Donna. It really is an honor and privilege. I have to tell you, I was overwhelmed by the support and the attendance and the attentiveness of all of you in the audience. It really is an honor and privilege. To see it firsthand, I think, as the president of the organization, we stand on the shoulders of many. But I can't think of anyone who's had a greater impact in the success of saving hundreds, maybe millions of patients' lives through the acquisition of data, maintenance of our database, and the ways in which you contribute to our programs. It's really extraordinary. So I'd like to say on behalf of the leadership that we are honored and privileged to be your partners in this process. I want to say thank you so much. As I was invited to speak, I think if I get to my slides that they are, I want to say again, thank you again, and offer a little bit of a perspective, because I understand that there are some folks who are new to the database, and maybe every once in a while it takes a little bit of time to step back and think about how we got here and potentially where we hope to go. So a little history about cardiac surgery and start the morning off right. But it's clear from my perspective that the future is now. And as I'm in 8 months of my time here as the president, been involved with STS for over 20 years. It really is a fantastic organization, but it is a volunteer membership organization to which we pay great homage to all of you and the volunteer leaders who contribute to our success. Ultimately, it's about the patient, and our patients benefit from all of your efforts, and we appreciate that. And we'll talk a little bit about what's on the horizon, and I think that starts us off for the day. So almost 50 years ago, many of you are aware, a little history, 1969, some extraordinary things happened. Apollo 11, space flight that landed the first man on the moon, was really an extraordinary endeavor. It took almost 20 years to get to that point, but it was a fantastic accomplishment. And could you imagine getting on the top of that rocket and ended up landing on a moon in a place that was really awesome? It was a signal that we could do some amazing things with ingenuity, hard work, and commitment of thousands of people, much like creating a database that can help save lives. Now, one of the things that we also learned is that getting feedback is a really important part of that process. And I think this meeting helps personify how other people have approached this in other walks of life. I'm sure you're aware of Elon Musk, who was a tech visionary behind Tesla and SpaceX and other issues. But he observed that the single most important factor in professional growth is to have a feedback loop where you're constantly thinking about what you've done and how you can make it better. I couldn't think of a better example of looking at this audience today. And the feedback that we receive from you is critically important to make us successful. In the same way, it's pretty clear that Elon was a remarkable innovator and has done some extraordinary things with that electronic car. And actually, it really is a remarkable activity. So we stand on the shoulders of many great volunteer leaders. And I want to congratulate and thank our physician leaders who volunteer their time and their effort, and many others who could be on this slide. But these are folks who we are proposing as constant in the leadership support for the database. And we're hopeful that as we introduce Felix and Danae, and we congratulate and thank Dave Wormuth and Jeff Jacobs as liaisons with the database coordinators, that they will continue to provide feedback about the database and be on a regular basis participating on your calls and hopefully provide you with that valuable insight, because they know the database inside and out. So we thank them and welcome them today. We also wanted to say congratulations to all of our staff. Again, these are the folks who work liaisons with you, and I want to say a special shout out to Donna, to Bill and Elaine, our new CEO, but also Leanne, and Jane, and Carol, and Kaylee, and Adelaide, and Emily, and say a prayer for Emily, Scott, Susan, Derek, Sydney, Mark, Catherine. All of them contribute to our success in the home office, and I know you will give them a round of applause for their efforts to keep the database on track, as well as to help make this meeting a success. So a little bit of history, and many of those in the audience may know this history, but the evolution of cardiac surgery has been remarkable since the early 1950s. And the first coronary bypass was performed in 1967. As you know, technology evolves with some early adopters, and then eventually it grows to be adopted based upon its success and the evolution of techniques which improve the outcomes. Many of those techniques are learned lessons initially, but eventually they become part of the fabric of how we do things, and eventually lead to the growth and development of the program. From the first blue baby surgery in 1944 until the current era, open heart surgery has grown significantly in this regard, using the technologies, the lessons learned, and the application and repeated perfection of our craft. So it really has been remarkable. The impact of coronary revascularization, as you're aware, with close to 7 million people in the adult cardiac surgery database, is that it can improve life, save life, and certainly make things better for most patients. And it's been remarkable to see the impact of the multidisciplinary teams on the outcomes of cardiac surgery in the future. And yet, not every patient is the same. Some of the historical considerations were in the early 70s, some of those patients who were older and sicker and had more challenging circumstances ended up being a challenge for us to manage. And ultimately, patients who had recent infarctions or shock or had other remarkable issues really were not the same as the basic ambulatory coronary bypass surgery. And so it became pretty clear that we needed some additional help in assessing their outcomes. And the National Surgical Quality Movement started with the Veterans Administration, looking at outcomes in the veterans. And they developed a National VA Surgical Quality Improvement Program, or NSQIP, was established in 132 VA surgery programs. Dr. Curry then established a national validated outcomes-based risk-adjusted methodology which could help level the playing field. And eventually, that was the evidence to support continuous quality assessment as a means to improve outcomes in a collaborative nature. And this is the history that led us to this point. And so, it's pretty clear other people were watching. If you don't know the history, back in the early mid-80s, in fact, the U.S. started to release mortality statistics, and in particular focus on those who had abnormal mortality statistics. So public reporting has been part of our landscape for many, many, many years. It's not just a current, recent thing. And with this advent of public reporting, it was pretty clear that we had to respond because not every patient was the same. Those patients who had advanced age, or had reoperations, or were emergencies, or had associated illnesses, they had worse outcomes than the routine cases. And so there was a risk factor assessment that said, wow, these things are having an impact on outcomes, and we should take full advantage of learning about that. And that helped to lead to the development of performance metrics to risk adjust clinical data. And that was critically important as a thought process. And again, some of our visionary leaders, including Dr. Clark, thought that this national database ought to evolve to try to address some of those issues, to risk adjust outcomes for coronary artery bypass surgery in an unprecedented manner. And there are others in the audience, Dave Sheehan, who have been at the center of this discussion for many years, who could elaborate on this more extensively than I can. But now, 25 years later, we see that that database and that vision has been extraordinary in terms of improving the outcomes of patients who have coronary artery disease, as well as lung cancer, as well as esophageal cancer, as well as congenital heart problems. The STS database, established in 1989,
now has well over 95% of the programs participating, with close to 7 million adult cardiac records in the file. So this is the current state of where we are, and you can see the penetration in the adult cardiac world is almost 90%. So we have you to thank for keeping us on track in terms of measuring outcomes and improving the lives of patients who have complicated cardiovascular disease. So our mission then, as a membership organization, is to enhance the ability of cardiothoracic surgeons to provide the highest quality patient care through activities like this, education, research, and advocacy. And it's really remarkable that we have such an audience here contributing to our success. We have over 7,000 physician members in 99 countries around the world. And we believe that we hope we can grow that participation as we move forward. By discipline, many of them are adult cardiac surgeons. Again, those who are self-reported, also thoracic and congenital surgeons. But our membership is broad and diverse. Congenital heart surgeons, perfusionists, nurses, as well as associated members who all contribute to the multidisciplinary care that we provide. Our databases have now grown with the adult and the congenital, as well as the thoracic and Intramax, to be successful in helping to report and collect information about our successes. So my point is that if we think about how the database works, we collect data with many of you helping to contribute, we analyze it, we measure it, we report it, we get educated by it, but it really isn't about measurement. It's about improvement. The ultimate goal is to improve the lives of those who are afflicted by cardiovascular disease, lung cancer, esophageal cancer, and congenital heart disease. It really is about improvement of their outcomes, and hopefully looking at things like our composite measures, we can help to improve their outcomes and ultimately predict outcomes before they have their surgery, based upon the data that's been collected using our risk calculator. So we can now predict to a patient whether the risk of a intervention is going to be 1% or 5% or maybe 7 or 10%. And so we have the ability to predict and potentially manage complications that could otherwise negatively affect their outcome. So we believe that these tools are invaluable to us as surgeons as to programs. Now, we still have opportunities to improve our overall performance. And it's always, this self-evaluation process has been ongoing for a number of years, but we want to make sure that you know that we're paying attention to your feedback about the database. And again, we know that we have to depend upon skilled data managers to complete data collection on paper or electronically. We understand that that is a process we can enhance. We know that the site reports can be aggregated at 6-month intervals, which aren't necessarily as facile or as efficient as we would like them to be. Obviously, we understand the media scrutiny, particularly some of our congenital programs, raises questions about risk stratification. And we have an active process now with our colleagues at Harvard, and I think John Myers here, and he's going to discuss some of those evaluations of the analytics of outcomes so that we can make it better for those who are practicing in that space. But also, it may help save lives. We understand, of course, that database participation is resource intensive. It requires a lot of resources from your institutions and your surgical practices to support it. And we know that the star rating system, although well-intended, can be misinterpreted by those who are not informed. What we really want to measure is how our performance, our observed outcomes, measure up against what's expected using the risk adjustment model. It's mostly for internal quality assessment and process improvement, not to compare us to other programs. Yet other people use that as an opportunity to compare 1 stars versus 2 stars, 3 stars. That's not the intention from my perspective. I believe we should be measuring it for our own self-improvement and giving us feedback regarding that measure. So our measurement is really important. It creates modernization opportunities for the database, and I think Felix and Vinay are going to discuss some of those things. We want our sites to be mobile and patient follow-up applications to be at your desktop, potentially. I know that you have said we want real-time feedback, reports and dashboards that would allow you to look at patient-reported outcomes on a regular basis. The ideal framework would be a web-based system that allows sites to manage data and report from one system, and I think you'll see that that's evolving. We want to develop modular participation fees, potentially discounts for high-volume centers. There's opportunities to respect and recruit your loyalty and commitment to our database, as well as to the improvements that it is evident. And we believe that there are growth opportunities to include our thoracic colleagues to have more full participation in the database. So, one of the unique things that people have commented about is that the database only gives you 30-day outcomes, mortality at 30 days. But this is an example of how linkage to medical records in the Intermax database has had a significant impact to tell us that we can look at data by linking with Medicare outcomes to see what the long-term impact is and validate that, in fact, the 30-day outcomes, the short-term outcomes really are representative of what's happening long-term, as an example. And so we see that some of that linkage is going to be really important. I raise that point because we are in the process of discussing a longitudinal data linkage through Northwestern University, and we think that's going to be a critical piece of data for you to have beyond 30 days. The objective of this project is to acquire longitudinal mortality greater than 30 days on reoperations, on demographics, on socioeconomic status, and then link that to the database. A huge opportunity for us to move forward. And that's going in real time. That NDI search file for those patients should be completed by the end of the month. STS anticipates that at some cost we'll get data, which will then be able to be linked to the results and outcomes, hopefully in the future. And by the end of the year, by July, we'll have some significant project movement that will give us long-term longitudinal data. So this is how the database is growing and developing, which will expand our horizons and be able to give us better predictive value. We also are working, and I know Dave and others have been extraordinarily helpful in building this individual surgeon performance report cards. We're committed to operationalizing this and developing a surgeon composite measure. Again, many people in the field, including a national quality forum, are looking forward to this. We hope that the goal is to have an initiative where surgeons on the individual level, for their own quality assessment and process improvement, will be able to look at their report card and determine how their results are being used and to help improve the quality of patient care. So we see that individual performance is really going to be important, but we need your feedback about how these tools are being used to help improve patient care and outcomes. Public reporting, of course, is the best opportunity for us to help improve performance. It promotes, in our belief, patient autonomy and allows them to know where the best programs are and how to get the best care. It's also a way to improve outcomes within your own program. It has a significant impact potentially on the consumers and the environment and the market, yet we understand that it really is going to be an important advent for future activities as we go forward. So we believe that it also will give us a better predictor. This was an initiative that happened a couple years ago with consumer health, consumer reports. It didn't, I don't think, get much traction. It did try to kind of report programs based upon a star rating system. We believe that we can do it better, and we have the opportunity with the data, risk adjusted, and managed well by our volunteer leaders and our programs to really have an impact. So, this is a slide that you'll probably see a lot of. It came from Joe Bavaria. I think that as we think about what's happening with our database, we know that the science tells us that we can improve lives with better surgery, and that guidelines can help us learn from best practices how to improve that outcome. But our clinical registries really tell us what we're doing and how to improve the outcomes on a real-time basis, and we hope that the continued advent of this program will make a difference. So the question I would ask you is, are these innovative efforts in quality and safety improving patients' lives? I think you could all answer that question for us. But others have looked carefully, and I congratulate Dave Shahan and the rest of the STS for being recognized. Last year, we were recipients of the John Eisenberg Patient Safety Quality Award, and at the national level, the Society of Thoracic Surgeons received the award in Washington. It really was a proud moment for us. It was an extraordinary thing. We received the award for innovation in patient safety and quality at the national level, and this award showed that we were among the best and the brightest in the country. It really was a remarkable thing and a real proud moment for the Society of Thoracic Surgeons, but it's representative of all the work that you have done. So all of you deserve as much credit for this award as does our organization. And with that, I'll say the future is bright for us. We are going to be streamlining our data fields as the database grows and develops. We're going to develop new quality outcomes and metrics via the NQF process. We're going to establish our public reporting structure. We're going to define our international participation with some of our colleagues in Europe, and we're looking forward to that. And we're going to strengthen our industry and FDA partnerships to help improve our overall mission. So it really is remarkable how we have come and where we hope to go. We believe the horizon is bright and the future is great for us. Oops. But we can't do it without your help. And so I'm fond of this saying that says if you want to go fast, go alone. But if you want to go far, go together. And I believe that we can only continue to improve our outcomes and the database success with your assistance. And I want to say thank you and congratulations for understanding that and joining us today. So thanks everyone very much.